Please, can
Can
you
you
see
see,
what is the problem?
can you
Your
see
voice,
my slides?
the echo is still there. Yes, we can see your slides
Okay,
perfectly.
thank you. Um, Over the next few minutes, I would like to discuss brolucizumab. As you know, there has been a lot of interest surrounding brolucizumab. Soon, India will have this drug available. It was approved in the US by the FDA in October of 2019. And since then, we've seen the drug available in Europe, in Japan, Australia, and many parts of the world. So it is important for us to understand what this drug is and what more it brings to our armamentarium of treatments of wet AMD. You have heard excellent talks from Professor Atul as well as Professor Vishali on the approaches that we now have largely agreed on in treating neovascular AMD. What we do need is something new, stronger, and longer acting. And I believe that brolucizumab gives us an opportunity for this. These are my financial disclosures. And before I start, there is a disclaimer from Novartis. So for today, I would like to talk about three aspects. The first is what are the unmet needs and challenges that we face in the care of neovascular AMD patients. I will then introduce what is the newest anti-VEGF treatment that we have available, which is brolucizumab or Beovu, and study in detail the clinical evidence from the pivotal trials called HAWK and HARRIER. Now, we all know that AMD is a problem that is here to stay. If you asked me 20 years ago how bad was this problem with AMD, I would say it was not as bad as diabetic retinopathy. But I think in many parts of the world, certainly in Singapore and Southeast Asia, this is a growing problem. And AMD has overtaken diabetic retinopathy as the major cause of blindness in people over 65 years old. And just look at the burden. The projected numbers already in 2020 are 200 million. And this is really going to increase exponentially in the coming years. Of course, I think if you've been in practice, in retinal practice for long enough, you would have appreciated the leaps that have been made, the great steps that have been achieved in the management of AMD. Remember that as early as the 1980s, there was really no disease, no treatment for this horrible disease, right? Vision loss because of no treatment was the rule. Even with thermal laser, for subfoveal choroidal neovascularization, you are going to lose 3 to 6 lines, but you would avoid 6 lines or more loss of vision. Now, I was fortunate to be involved when photodynamic therapy with verteporfin was made available in the early 2000s. Even then, it was like cutting off one finger to save the hand. And we did not have any satisfactory treatment that could improve vision until the arrival and introduction of ranibizumab, the first anti-VEGF therapy. Well, I would say not the first, but probably the most effective anti-VEGF therapy at that time compared to Macugen. Before that, if you recall, we had a short period, 2004 onwards, where we had pegaptinib or Macugen, which had a very similar result to photodynamic therapy. Now here we are at 2020 still talking about the evolving spectrum because I think we are far from achieving perfection. We are nowhere near that. And we really have to look at how we can improve and optimize vision further. In particular, we are now faced with the burden of frequent treatments. These patients who have been successfully treated and have their vision improved or even restored continue to require long-term therapy. Overall, you can see worldwide, in many parts of the world, and I'm sure this is true in India as well, that the incidence of blindness has been significantly reduced with the introduction of anti-VEGF therapy. So we are already talking about a fantastic revolution in our times. I think many of us would not have dreamt when we started out in our careers of something as marvelous as the anti-VEGF revolution. Nevertheless, we should not rest on our laurels. Look at the undertreatment in the real world. With the randomized clinical trials, you get decent results, plus 10, plus 11 letters. But in the real world, this is really not so. Even in countries with very good reimbursement systems and good social networks, for example, in Australia, you're looking at a plus 5 letter rather than a plus 10 letter gain in the real world. And in some countries, even in developed countries in the West, from the oral study, for example, really the results were quite disappointing. Luminous, for example, showed that over 70% of patients currently are undertreated in the first year of therapy. We know how important it is to be aggressive in introducing treatment in the first year. On average, you would require at least 7 or 8 injections of any anti-VEGF to achieve the optimal results we see in the pivotal trials such as Marina and Anchor. Now, there are several barriers that can lead to this undertreatment. The most important, I think, is treatment burden. In many countries, like in Singapore, the drug is not reimbursed, and so patients find it financially impossible to sustain long-term, frequent, regular, expensive treatments. Then, of course, the system itself can be stressed. There are too many patients who require our care. Then, of course, the patients at their age group may need help at home as well as in coming to the clinics. And last but not least, education. So I would say that the scorecard for how we are doing currently with our management of neovascular AMD is mixed. Yes, we have done well in terms of proven efficacy. We have done well in reducing blindness from neovascular AMD. So all that's well and good. But I'm sure you will agree with me that there are many challenges that are still yet to be overcome. For example, maintaining long-term efficacy, reducing frequency of treatment and monitoring, that's a real challenge for my patients. Reducing burden on patients, and I'm not just talking about financial burdens, plus their caregivers as well as healthcare resources. So I think there is a lot more work to be done as a community of scientists. But let me now introduce what we have at the moment. The newest anti-VEGF, which has been approved in many countries, is Brolucizumab. Now, what is Brolucizumab? It is the most clinically advanced single-chain antibody fragment currently available and designed specifically for ophthalmic use. Now, this is the full-length antibody. I think most of you are familiar with both the variable as well as the fixed domain chains, so the two FAB as well as the FC portion of the full-length antibody. And typically we would have seen this with bevacizumab. Now, the ends of the variable fragments, both heavy and light chains, are marked by these small, tiny regions known as CDRs. Now, the CDRs are called complementarity determining regions. These are the exact antigen-antibody binding sites. The rest of it is to stabilize and to support these binding sites. But it is these CDRs that are responsible for binding to the antigen. So in this case, we are talking about VEGF, right? So these are the VEGF binding sites. Now, if we were to isolate just the CDRs of the entire antibody, this is where the VEGF would be bound, but obviously the CDRs cannot exist on its own. So if you couple that and graft it on a human single chain FV scaffold, you then end up with the final very small molecule. Note that there are only the CDR regions plus the variable region. There is no FC portion at all for this drug. And that's how we end up with Brolucizumab. It is only 26 kilodaltons in molecular weight. Now, this is a nice comparison with what we are currently using, a Flipset, which is a fusion protein, here about 100 kilodaltons. Ranibizumab we are also very familiar with, which is the FAB fragment, and is clearly about double the size in terms of molecular weight compared to Brolucizumab. In terms of clinical dose, aflibercept is 2 milligrams, ranibizumab a standard dose of 0.5 milligrams, and brolucizumab is a whopping 6 milligrams. Now, in terms of relative number of molecules, because of the very small size and molecular weight of brolucizumab, we are able to pack in 12 times the number of molecules per injection compared to a similar injection with a aflibercept. So this is clearly an advantage. This engineering is really to do a few things. You achieve more drug in a single injection. You have then potent inhibition of VEGF-A. In fact, the affinity measured through a coefficient constant is a higher affinity for VEGF with brolucizumab compared to aflibercept. And because of its small size, rapid and effective penetration of the retina into the choroid and very rapid clearance from the systemic circulation. The last is important because these are elderly patients who might have coexisting cardiovascular morbidity, and a rapid systemic clearance will greatly reduce the risk of thromboembolic events or APTC events. Now, HAWK and HARRIER are important because they were the phase 3 pivotal studies for brolucizumab in neovascular AMD. HAWK was a 2-year study randomized into 3 arms of treatment. You see these as 3 milligrams and 6 milligrams of brolucizumab, almost 360 patients in each arm. And the comparator or control was aflibercept 2 milligrams, also 360 patients. HARRIER was only 2 arms, brolucizumab 6 milligrams versus aflibercept 2 milligrams. And the primary endpoint was a non-inferiority of BCVA change at week 48. Now, this was a multi-center trial. Many parts of the world participated, including Singapore. HAWK were really global sites, especially the US and Japan, Australia and New Zealand. And the rest of Asia, Russia and Europe were in the HARRIER study. But the design was similar. If you look at HAWK and HARRIER, the comparator was aflibercept. These patients all received the first 3 loading doses at 4-weekly intervals, followed by 8 weekly subsequent fixed treatments. So this is as per label. Now, with brolucizumab, either 3 or 6 milligram, depending on which study we're talking about, the 12-week treatment was of course omitted. There is no treatment after the first 3 loading doses. 8 weeks after, at week 16, this is a very important point in the study. It is for disease activity assessment, and thereafter you see disease activity assessments at week 20, 32, 44, 56 and so on. Now, why is 16 important? Because at week 16, disease activity was important in determining whether patients were eligible to go on Q12 or they needed to go on a more frequent Q8 regimen. So for example, if the patient was deemed not to have disease activity at week 16, he would then be placed on a week 12 regimen, such as here, 20, 32, and 44. And at each subsequent disease activity point, if there was disease activity, the patient would then drop back to a Q8 regimen and would stay on a Q8. There was no chance in this study for him to go back onto Q12. So this was actually quite a high bar for patients to remain on a Q12 throughout the study, and you will see later why I say that. Now, the primary endpoint, as I mentioned, was non-inferiority between the treatment regimen, brolucizumab, either 3 or 6 milligram compared to 2 milligrams of aflibercept at week 48. And the non-inferiority margin was set at 4 letters. This is in keeping with many other studies. I won't go through all the secondary endpoints, but I will show you the results. This, as mentioned, was a disease activity assessment criteria, very similar to what we use in clinical practice. Visual acuity decrease, as well as fluid, new fluid, especially intraretinal cysts, were all important markers of disease activity. Remember that all these were all based on the discretion of the treating physician. Now let's look at the primary results. The primary endpoint was met at week 48, meaning that brolucizumab in both doses was non-inferior in achieving visual acuity gains and maintenance compared to aflibercept of 2 milligram. Here you see the 2 curves, the 3 lines overlapping. And this continued right through to week 96, which was the end of the study. So for both Hawk, which is the top, and Harrier, there was non-inferiority between brolucizumab and aflibercept. So the primary endpoint was met. Now, why do we say that brolucizumab is a longer acting anti-VEGF, at least compared to aflibercept? Well, for one, over 50% of brolucizumab 6 mg patients could move immediately after loading phase to a week 12 dose interval. This is really significant. 56% of 6 mg and 51% of 6 mg in Hawk and Harrier respectively could move immediately from 4 weeks to 12 weeks. Many people ask me, what is the big deal about 12 weeks? It is a big deal because when we do treat and extend with either aflibercept or ranibizumab, only 20 to 25% of patients are ever able to maintain their intervals at Q12. And that is after a long period of time. Most times we can only move up to Q12 at the end of the first year. Here, at week 16 onwards, the patient is put on a Q12 treatment interval. In terms of predictability, this was very good. 82% in Hawk, 75% in Harrier of patients who were on Q12 at week 48 remained on Q12 for the rest of the study in the second year. In other words, once you are able to continue in the first year with Q12, you are likely to only require 4 treatments a year subsequently. Next, I want to show you some evidence that brolucizumab is a stronger anti-VEGF than aflibercept, at least in this study. Here you clearly see that the reduction in central subfield thickness was very impressive with brolucizumab. Compared to aflibercept, where in aflibercept you still see this seesaw pattern, meaning that fluid starts to come back towards the end of the 7 or 8 weeks in between aflibercept injections. Remember that over 50% of the patients with brolucizumab were on Q12 treatment. So this is, I think, a significant improvement over aflibercept in terms of control of fluid. And indeed, when we look at disease activity as a whole, and we looked at disease activity through presence of fluid anywhere, new hemorrhage, growth of choroidal neovascularization, the typical criteria, there is a clear advantage and statistical benefit of brolucizumab over aflibercept. Here you see in both studies a consistent picture. A 30% lower rate higher rate of no disease activity achieved with brolucizumab. What if we break this down into compartments of fluid? You heard from Professor Vishali how important fluid is and the relative importance of the different compartments. The most important compartments obviously are the intraretinal and subretinal fluid. Fewer patients on brolucizumab had intraretinal and subretinal fluid for all these weak points, 16, 48, and 96, when compared to aflibercept. And these are impressive figures, 35%, 36%, 40% reduction in the presence of fluid when you use brolucizumab. In other words, there is consistent and clear evidence of greater drying impact of brolucizumab over aflibercept. And this extended to sub-RPE fluid as well, the same proportions, about 30 to 40% stronger action in terms of drying fluid in the sub-RPE space. And this is not surprising because of the small molecular size. We expect that this drug gets to the deepest layers of disease pathology very quickly. So overall, you see that more patients achieved complete fluid resolution. After all, this is what we are trying to achieve. We don't want to see any fluid as much as possible, since you heard from Professor Vishali that all fluid in the macula is pathological. Similarly, you see in Harrier the same results. More patients could achieve complete fluid resolution with brolucizumab compared with aflibercept, and all these are highly statistically significant. You also heard about consistency and the control of fluctuation. It's not so much only reducing or eliminating fluid. We do not want any fluctuation as far as possible, because we know that the more fluctuation there is, the worse the final visual outcome. Here you have good evidence of how brolucizumab can control and minimize fluctuation. To achieve 3 or more consecutive fluid-free visits is not easy, even with the best treatment that we currently have. But here with brolucizumab, you find that the incidence of at least 3 consecutive fluid-free visits was significantly greater with brolucizumab. Here you see about 24% greater chance in HAWK and 43% increase of at least 3 consecutive fluid-free visits. All these point to greater durability and more consistency of action. This is a typical example of patient who had received 6 milligrams, 3 initial loading doses, and week 16 found not to have disease activity, therefore put on a Q12 treatment regimen. And within the first 16 weeks, the macula is already dry. Not only is subretinal fluid eliminated, but sub-RPE fluid is also greatly reduced, if not totally eliminated. And by week 48, the macula is flat and dry. Up to 96 weeks, it is well maintained. So these patients maintain very stable vision with no recurrences and no fluctuation. I think the last bit which I want to discuss and maybe spend a bit of time on is safety. For any new drug to be useful and widely used in the community, it has to exhibit well tolerated in terms of safety. Now, if you look at HAWK and Harrier, the results were good. In 3 milligram, in a 6 milligram doses compared to aflibercept, there was no statistical or significant difference in adverse events, either in serious adverse events or even non-ocular thromboembolic events. Here you see with 6 milligrams, it was 2.8%. In HAWK, aflibercept was 4.4%, not statistically significant. In the Harrier, so with 6 milligrams, it was 3.2% versus 3.8% with aflibercept. This is for the APTC event. So there was no signal of systemic serious adverse events. But in terms of ocular safety profile, there has been quite a lot of attention paid on inflammation. Here you see with the original HAWK and Harrier data, we had 4.7 and 5.8% of intraocular inflammation in HAWK and 3% of inflammation in Harrier when we use brolucizumab. And this was higher than the aflibercept 0.6, 1.1, although these were not statistically significant. And also retinal artery occlusion was a low 1.1% in HAWK and 0.5% in Harrier. And there was no significant difference in terms of endophthalmitis. As you know, when the drug was first approved in the US, post-marketing, there were reports, isolated case reports of patients who developed severe inflammation, including occlusive vasculitis. And some of these patients who developed occlusive vasculitis actually lost vision and did not recover. So obviously this was a great concern for all treating physicians, not just in the US and worldwide. And so there was a review of all patients in both HAWK and Harrier to relook whether the inflammatory rates were correct. And indeed, they were not different. You'll see that after rounding up, it was 4% of intraocular inflammation with brolucizumab compared to 1% with aflibercept. In terms of retinal artery occlusion, it was 1% still, and endophthalmitis, it was 1%. Nonetheless, I think there are unanswered questions about the etiology and who are at risk for this inflammation. And I think it will be useful later when we discuss to also seek the opinion of the other panelists, and I know many of you are very experienced with inflammatory eye disease, for your thoughts about what could be causing these inflammations and how we can identify early and perhaps treat them. So to summarize, we now have brolucizumab, the newest anti-VEGF agent, which has shown to be stronger and longer acting than aflibercept. This goes a long way in helping us meet some of the unmet needs, such as treatment burden. So we have this potent novel drug. And phase 3 studies like HAWK and Harrier have now confirmed that in terms of visual acuity, brolucizumab was non-inferior to aflibercept. But more importantly, it had superior drying effect, anatomically better than aflibercept in terms of both intraretinal, subretinal, as well as sub-RPE fluid and overall disease activity. Coupled with this, we see less fluctuation in the central subfield thickness, which is really important for long-term maintenance of the photoreceptors. Last but not least, we have an opportunity now to have a longer acting drug. Successful completion to a Q12 interval at week 48 was possible in over 50% of patients. And once you could achieve that at year 1, there was a high probability that you would be able to continue on a Q12 interval up to week 96. And overall, the safety profile was comparable to that of aflibercept. There was no statistically significant increase in ocular or systemic adverse events. So I'm really excited about how we can incorporate brolucizumab in our current armamentarium of treating neovascular AMD, and I'm confident that this drug will be a very useful addition to what we have. Once again, thank you very much, and thank you to the AIOS for allowing me to speak at this forum.